Hello everybody, my name is Yahya Ithawi. I am a neonatologist and a pediatrician, and today I'm going to talk about the second episode of the feeding issues in an ICU. The first one was about some feeding tips for nurses, and this one is how to initiate a feeding order, to start the feeding and order between that communicate between physician and nurses and other healthcare providers for newborn babies. So to start the order, it's vital to give some biography or document some biography to facilitate the understanding of the order between the prescriber and the executor. For example, the weight of the baby, the length, and probably service area. And the TFI, either you write it again or you take it by default from other orders. It's variable whether you're using paper documentation or you're using a system. So it's very important to give details of the total fluid intake, how many ml per kg per day, what is the total, and how many ml per order as a general fluid rate. It's also wonderful if we can include either bring it with the screen in the system order or type it or provide a paper of it when you're writing a paper order. These electrolytes, all of the electrolytes are important with the feeding, CBC, hemoglobin, and also there is a gas. And after that, we have to state the order priority. Are we starting the feeding now as a start order, or it's urgent to be done as early as possible, or it's routine, then I was going to start it whenever times permit. Or it's a time critical, or which means that we're starting in a specific time. And it's also very important to state whether you want this order for 1 day and then reassess, or 2 days, or 3 days, or any other duration of feeding. It's vital to state what type of milk you're wanting. Are you doing a breast milk or are you doing formula? And what type of formula? Is it premature or full-time? And we will detail that in the next few slides. Or you're using mixed breastfeeding and then formula, or using basically whatever mom can provide if she's expressing the milk and top it up with formula. And are you fortifying using human milk fortifier to increase the nutritional values and caloric density of the milk? So you have to state no fortification, or you're fortifying with 50 ml, or you're concentrating the fortification by making it double. Of course, the fortification will not happen on the first day, but I mentioned that because you need to include this order. You can say that start fortification on second or third day, or when this level of amount of milk is reached. And then you need to state what is the density or the caloric density of the formula you're prescribing. Are you using the 20 kilocal per ounce formula, which is usually called TAM formula, or you're using the 22 kilocal formula, which is what again was called discharge formula, or you're giving high caloric density formula, 24 kilocal formula, or a premature formula, or using more concentrated for additional nutritional values, high caloric density formula like 26, 27, 28, and even 30 kilocal per ounce formula. Either the system calculate the calories by automatically, or you have to calculate it. So we need the number of kilocal per kg per day getting from the feeding, because we need to calculate other calories from IV fluids and IV nutrition. And it's also important to state in two forms, per kg per day and per day. And also you need to state whether you're adding some other additives, like some milk powder to concentrate This is a spelling error. I meant Infacare. So you have to state whether you are adding more additives to increase the caloric density. For example, if you don't have 27, you're using 24, but you need more calories, you can add some powder to increase the calories. And what is the amount? You need to state what is amount. Are you using 0.5 gram, 1 gram, 1.4, 2, 2.7, 3, or 4 grams per 100 ml or per 50 ml? You have to specify that, and then also this should be calculated as a calories per kg per day and calories per day. Are you adding protein? If there is protein, if the growth is not optimum, or you have some metabolic acidosis due to low caloric intake, and the body start to use the amino acid, so you can decide whether to add protein for, and the dietitian opinion here are very vital. And what is the amount of the protein? Is it 0.1, 0.2, 0.3, or 0.4 grams per 100 ml or per 50 ml? And then you need to tell the nurse or the healthcare provider how you want the feeding to go on. Do you want protocol feed? And there are protocol feed for each birth weight. I will discuss it with next episodes. So the protocol feed is the way of feeding or way of incrementing the milk from very small amount to full feed, how you want to do, and there is a protocol feed for each specific birth weight. Do you want it ad lib demand, which means the child can take whatever amount whenever he or she wants, or ad lib demand, she or he can take whatever they want, but they should not go below certain limit, and then you have to detail that certain limit. Do you want it as a bottle feed or a gavage feed through a tube from the nose or from the mouth? Are you starting with MEF or not? We've discussed the MEF or minimal enteral feed or trophic feed. We've discussed it in a previous episode. And then by telling the whether you need a gavage feed, not a bottle feed. The bottle feed, if the baby is going fast, sucking the feed, I would interrupt the feed to make it in at least 20 minutes. And because if the baby feed very fast and he's sick, despite he's getting by bottle, he might vomit or not tolerate the feed. So it's important to, for recovering infant, for small infant, for a sick infant taken by bottle, to interrupt the feed to make it not less than 20 minutes. Or if you're giving gavage, then also and you're stating bolus, you should not give it below 20. And for some reasons that we've discussed, you need to avoid the complication of feeding. Or you want to give it more than 30 minutes, continuous, but interrupted. So it can be like 45 minutes every 2 hours, or 45 minutes every 3 hours. Or it can be 60 minutes every 2 hours, or 60 minutes every 3 hours, or it can be 90 minutes, or 120 minutes. So these are called continuous intermittent, to give more time the baby to digest the milk, but also give him or her a gap to be free from the feed and digest and relax. Or you want to wait because you have a feeding intolerance, the child is a little bit sick, you don't need to overload him or her, so you go by continuous feed. You can also state other instructions in your order, whether you're using a paper documentation or a system, by stating what is the amount of the minimal feed. So are you giving, for example, if the child can achieve 120 ml per kg per day, that's his or her minimum. If he can get above, then all is good. If getting below that, then you need to top him up. Sometimes in certain situations, you need also to state the max. What is the max? For example, if you have a renal problem or you have a fluid problem, you don't want although he or she is taking a good amount, but you don't need to exceed a certain limit. So these are special considerations you need to be aware of when you're writing a feeding order. And then we go to details. We decided about breast milk and additives and fortifiers, but also you need are you using a special formula? So you need to say yes and no. And if it's yes, then what type of the special formula? They have many types of special formula for rare problems, but also we have more commonly used partially hydrolyzed protein formula that is used for certain cow's milk or protein allergy, or fully hydrolyzed amino acid elemental formula, or thickened formula if we have kind of regurgitation. And then you can state other types, especially for metabolic diseases or special consideration. If you said others yes, then you need to state the type. And you need to give some instruction in certain situation. And these are tips for writing the instruction. So for example, if a premature baby, you need to use the premature 24 kilocal per ounce formula, and this will give more nutrition because these babies need to grow fast. They have limited amount of fluid they can tolerate, and also they need to grow fast. They need to do catch-up growth, so they need more calories. So it's being used for preterm babies, but also can be used for term babies when they are low birth weight, less than 2,500 grams. And this formula, any high density formula more than 22, should not be used outside the hospital because of its need monitoring and because it's load on the kidney and need electrolyte and making the weight and monitoring for feeding complications. So this type of formula is not allowed to use outside the hospital. And this type of formula, it's better to be ready-made diluted formula than powder. Nothing wrong with powder, but it would have more complication because of the color, because of the caloric density and need very accurately determined. So using it as a ready-made is way better. Other instruction, if you are using the 20 kilocal formula, this is for 10 babies, but also can be used for the 10 babies more than 2,500 grams of birth weight. Also can be used for premature babies when they achieve more than 3,500 grams, whether inside the hospital or outside the hospital. When we use a milk powder like Infacare as additive to increase the collagen, should not, this type of additives should not be used at birth. You can use an MEF at birth, but fortifier and other additives usually is not at birth. Usually we started when the child achieved like let's say a certain limit of feed, let's say about 50% of his total fluid requirement is as feeding. Probably somebody can try. Baby is not sick and is metabolically compensating. So most of these additives used for baby are very low that we want them to grow. So the limit is 1,500 grams for babies less than 1,500 grams. I think sometime we can add to those then to add to the babies whose their birth weight more than 1,500 grams, but this is very rare and needs special consideration. For 24 kilocalorie can be used also for term infants who either they weight less than 2,500 grams or they are not achieving a certain growth goals, or they are restricted by fluid for certain reason, and then we need to give them the same amount of calories but with restricted fluid. Or for babies who have increased metabolic demand, like in cardiac disease, or a baby who's withdrawing from a substance that the mom was taking, whether it's a legal or illegal drug. The partially hydrolyzed formula, the special formula, is used for malabsorption and bowel sensitive, to the protein of milk. For fully hydrolyzed, it's elemental, it's amino acid, it has no protein, and used also for cow milk and protein allergy. Thickened formula, I don't advise to use it. It should be used when other resources are out. And it should be a meeting discussion between a consultant neonatologist or a pediatrician and a dietitian. And also need to be discussed with other team members and other disciplines, like occupational therapists and maybe also the family. So by this, I end this topic about how to write the initial feeding order. So this is the only initial feeding. These are tips for starting the feed. And then with time, when we will talk about other episodes of feed, we will continue to change this feeding orders with monitoring the baby and talking about some protocol feeds and complications and combining complications with protocol feed to readjust the feeding orders. Thank you for watching this. Hope you click prescribe and activate the bell. And I hope I see you in next presentations and next episode for this topic and other topics. Thank you very much and have a good day.